one emailed question asking about the diagnosis and management of atypical Kawasaki's disease.
Okay.
And how that may differ from regular Kawasaki's.
Okay, also known as incomplete Kawasaki's. So this is a very difficult diagnosis to make. It basically, if you can remember the criteria for Kawasaki's, if you satisfy 4 out of 5, then you can make the diagnosis of Kawasaki's, and that's fever plus the other symptoms. In the absence of those 4 other symptoms, you still may have an incomplete Kawasaki's. In other words, you have the same sort of underlying physiologic process, meaning an inflammation, a vasculitis that is primarily targeting the cardiac vessels. Incomplete Kawasaki's was first recognized in the early to mid 80s. This is about 15 years after Kawasaki's itself was discovered. And the problem with incomplete is exactly what it sounds like. You don't have enough clues to be able to say what's going on. So you have to have a very low threshold for considering it. And what's that threshold? Certainly in a child who has a fever for 5 days or more and doesn't have a real good explanation for it, you should be thinking about it. If you have 1 or 2 of the typical symptoms of Kawasaki's, so maybe you have the non-purulent conjunctivitis, or maybe you have the swelling of the hands, or maybe you have the oral changes, or maybe you have the rash, and there is no specific rash for Kawasaki's. It tends to be a non-specific rash. Or maybe you have that unilateral lymph node in the neck, and it is unilateral lymph node enlargement that is typical for Kawasaki's. So if you have 1 or more of those physical findings and you have a kid with a fever of 5 days or more, you should be thinking about atypical Kawasaki's. Why is this important? Because the rate of cardiac complications, meaning coronary artery aneurysms, is at least as high with incomplete Kawasaki's as it is with regular Kawasaki's. So how do you make the diagnosis? First of all, you need to suspect it. Second, the first and most important lab, in my opinion, is the Sed Rate. If you have a normal Sed Rate, it is for all intents and purposes, you have ruled out Kawasaki's. Not 100%, but almost without exception, in Kawasaki's, you will have an elevation in your Sed Rate. So you get your Sed Rate back and it's 85. What other labs are helpful? Well, the American Heart Association and the Pediatric Cardiology Society have published a paper. This came out about 6 or 8 years ago now, maybe a little bit more, detailing how to make the diagnosis of incomplete Kawasaki's. And what they suggest is to get some other labs as well. So a CMP. If you have an elevation, I think it was AST or ALT or both, an elevation in your white count, sterile pyuria. And remember, when you're looking for sterile pyuria in Kawasaki's, don't get a catheterized specimen. The pyuria from Kawasaki's comes from a urethritis. It's an inflammation of the urethra. If you put a catheter in to get your urine sample, you're bypassing that inflamed urethra, and you may get a clean urine. So this is one of the few times where you want to get a bag specimen so that you can see whether there's inflammatory cells there. Leukestrase will be negative. The inflammatory cells are monocytes. The leukestrase is not measuring monocytes. So leukestrase negative, but you have a lot of white cells on your microscopic. You should be thinking that in terms of urethritis, and that goes along with Kawasaki's. So if you have a kid like this where you're suspicious of incomplete Kawasaki's, what I would suggest is Google the American Heart Association paper on incomplete Kawasaki's, because it's a very complex algorithm, and every time I get a kid like this, I always pull it up just to make sure I'm not missing something. But if you can get, I think it's 3 out of 5 laboratory abnormalities, plus an elevated Sed Rate, plus a fever, plus 1 or more of those other symptoms, then you can make the diagnosis of incomplete Kawasaki's or atypical Kawasaki's.
So I think that the main trouble here is even thinking about it. Like once it crosses your mind that this could be, because you're going to have to see dozens and dozens of just boring URIs before you pick up that kid with Kawasaki's, and just remaining vigilant. If you're going to be sending labs on a kid that looks a little bit sick, consider the ESR, but remember it's going to be incredibly non-specific because tons of things are going to elevate your ESR. But if it's negative, you have more or less ruled out Kawasaki's disease. I mean, incomplete Kawasaki is so challenging that you almost certainly are going to miss one if you see enough kids, but just remain vigilant.
Maybe, yeah. So the problem I had with it looking at it was a lot of these labs, like you said, are acute phase reacting towards the mic.
Well, just pick it up. You're right there.
Come on,
You're tall enough to where you're practically there.
Dr. Janiak could slap my hand away. So you're talking about a lot of acute phase reactant stuff you'd expect to be elevated in a fever anyway.
Not necessarily a Sed rate. The Sed rate shouldn't be sky high with most viral infections.
Well, sky high, but elevated. A big jump between those two statements. And so you have these acute phase reactants and something as non-specific as general rash in a fever, which could be viral exanthem.
Right.
Here, it's not that big of a deal because we have the carte blanche to kind of admit people where we have a concern. But if you're out in the world, at what point are you hammering these kids with aspirin and going after IVIG and transferring them in lights and sirens because you're concerned with that? I mean, it's a big jump from this kid has a viral issue that just happened to present with 5 days of fever and a rash versus this kid has a incomplete Kawasaki.
It is a very bold peds hospitalist that is going to say, look, you're concerned about incomplete Kawasaki disease and I'm refusing to accept it. Like that is a huge, bold maneuver. I mean, sure, it's messy because, like you mentioned, ESR may be slightly elevated. Usually this is not going to be a subtle elevation of the ESR. It's going to be quite high for most of these folks.
Yeah, and these kids are really sick-looking kids. I mean, the original description was that they're almost toxic appearing. They're really sick. They're miserable kids. There's lots and lots of viral infections that we see in the ED that have pretty much just fever and rash and nothing else. And this is not a plea to you guys to be sending all these kids on to tertiary care centers. But if you've got that same kid who has fever beyond 5 days, most of these viral exanthems, the fever is going to last maybe 4 or 5, 6 days, but not a whole lot longer than that. I mean, even measles doesn't last a whole lot longer than that. So there are a couple of exceptions to viral infections. I mean, hand, foot, mouth, you can get fever for up to 10 days. It's an enterovirus, and that's typical. But enterovirus tends to be an outlier. The rest of the viruses, you got relatively, shorter periods of fever. So if you got somebody that's still got a fever after 5 days and has a rash and is absolutely miserable, would I be thinking about atypical or incomplete Kawasaki's at this point? Yeah, I might start to entertain it at that point, beyond 5 days, but not at day 2 or 3.
So if you're out in the world, would you be giving aspirin to these kids and sending them on?
Well, what I was going to say is, like he said, the biggest thing is to think about it because the treatment for incomplete and complete is the same. So they're still going to need the aspirin and the Solu-Medrol. They're still going to need the echo and the follow-up. So if you're thinking about it, even if you don't admit that kid, you have to treat them and have close follow-up with cardiology because they're still going to need those serial echoes. And surveillance.
You said Solu-Medrol. You meant immunoglobulin.
Immunoglobulin.
So aspirin's a pretty benign drug. IVIG is catastrophically expensive. And so I don't think you'd be wrong if you're out in some community place. You give the kid a bunch of aspirin, send them to the big hospital down the street. That's okay. All you did is use an old, good NSAID that's probably going to make their fever feel better anyway. It's okay.